case presentation. So I would be requesting for short case Dr. Vidya K. Zakaria from Jipmer, Pondicherry. Examiners for this case will be Dr. G. Swarnalata ma'am, Professor and Head, Department of Nephrology, NIMS, Hyderabad, and Dr. Anuradha Raman ma'am, Director and Head of the Division of Nephrology, Sunshine Hospital, Paradise, Secunderabad.
Good afternoon all. My patient is Miss Parkavi, 23-year-old female from Tanjavur. She had done a diploma in nursing and is currently working as a staff nurse. History is obtained from patient and mother. Presenting complaints: abdominal pain for 10 days, cloudy fluid in the peritoneal dialysis drain bag for 9 days. History of present illness: I would like to start my history with the background history. My patient is a first child born to a second-degree consanguineous marriage. It was a booked pregnancy and had regular antenatal visits. There was no history of diabetes mellitus or hypertension diagnosed during pregnancy. Anomaly scans were told to be normal. She had, it was a full-term vaginal delivery with a birth weight of 2.9 kg. There was no ICU admissions or any surgical interventions in the early postnatal life. Baby passed stools and urine on the first day and they were discharged on day 3. According to mother, baby had a normal postnatal life and was gaining weight normally and received all vaccination appropriate for age, and during those visits was told to have a normal weight gain also. Child used to pass urine of low volume with thin stream and increased frequency, and whenever urine was passed, she used to pass stools also in small quantities. There was no crying while micturition, no straining while micturition or decreased feeding, and mother considered this to be normal till 4 years of age when she started having recurrent episodes of fever, and after for which she was evaluated, and after investigation she was told to have urine infection. Imaging studies were done and she was told to have a problem with bladder and that her urine was going back from bladder to kidney, causing infection. So further investigations were done, and at 5 years of age, she underwent a corrective surgery for this. It was told that the defect was not completely reverted. She was advised to do intermittent catheterization herself every 2 to 3 hours. She had good urine output of around 1.5 liter during this time. Patient was otherwise asymptomatic as per mother, but continued to have on and off fever. Mother cannot recollect the frequency of fever episodes, and she is not sure whether she was on any daily medicines. She is also not aware of any blood reports during that time. Intermittent catheterization was continued till 7 years of age. Patient was otherwise active. She used to go to school regularly and used to play with her friends. Because of this difficulty in intermittent catheterization, they consulted another hospital at 7 years of age when she was told to have a creatinine of 6 and irreversible kidney damage. She underwent another surgery after 1 unit of blood transfusion and had an opening created on the left lower abdomen with a bag attached to that opening for urine collection. Urine output was around 1.5 liter per day. She was started on medicines during this admission, which mother recollects as Sodament, Livogen, calcium, amlodipine and labetalol. Further, she did not have recurrent fever episodes. She was told that she will require dialysis and kidney transplantation later. She was on regular follow-up. She had a normal schooling and average scholastic performance. She did not have any bony deformities, difficulty in walking or bone pains. On follow-up, she was told to have gradually increasing creatinine. She was lean during the growing up age. She was lean and short compared to her friends. There was no additional vaccines given to her. In 2017, when patient was around 16 years of age, she was told the need for dialysis initiation due to high creatinine levels. Her urine output during this time was 1 liter per day. There was no history of nausea, vomiting, pedal edema. Mother says that she was otherwise asymptomatic. She was given an option of hemodialysis and peritoneal dialysis, and family opted for peritoneal dialysis as it would be better for her schooling. Patient was admitted, and after 1 unit of blood transfusion, PD catheter was placed percutaneously on right side of abdomen. Procedure was uneventful. Regular exchanges were started, and as patient wanted to attend classes, she was advised to keep abdomen dry during the morning hours, and night 1.5% 1 liter exchanges of 4-hour delves was given. Her urine output was around 1 liter as mentioned during this time. She doesn't recollect the drain volume during that time, and her PD was told to be functioning normally. She was started on erythropoietin injection weekly and iron sucrose injection after investigations. 4 months later, after insertion of PD catheter, she had cloudy drain fluid and abdominal pain. She was evaluated and told to have infection in the PD fluid and was given antibiotics after admission through the PD fluid for 2 weeks. Regular medicines were continued during this time. She was treated and discharged on the same prescription of PD, peritoneal dialysis. The transfer set was changed and further changed 6 monthly. After 1 year, she had a similar episode of cloudy fluid and was treated similarly. She was admitted for around, again for around 2 weeks. There was no catheter removal, reinsertions or temporary requirement for hemodialysis. She attained menarche at 19 years of age and she has irregular menstrual cycles. She attains cycles once in 3 or 4 months. During these menstrual cycles, she would be having blood stain dialysate, which would clear its own after 2 to 3 days. There was gradually decreasing urine output over these years, and last year her prescription, peritoneal dialysis prescription was changed to 2.5%, 1300 ml, 3 exchanges during night and dry during day. Before this change in prescription, there was no history suggestive of any PET test or adequacy test done. Currently, she is symptomatic for 10 days. Patient's symptoms started as abdominal pain, which was diffuse and continuous in nature. There was increase in pain during infusion of PD fluid. No history of vomiting, loose stools or constipation or fever. There was no history of accidental disconnection of PD or any discharge from the exit side. Next day, she continued to have abdominal pain and she noticed cloudiness in the drain and was evaluated for the same. Initially, she received antibiotics through the peritoneal dialysis fluid from nearby hospital. Pain was persistent and she had fever spikes and there was gradual decrease in the amount of drain volume. She used to have 1 liter of drain during this time before this episode, which decreased to around 400 ml. There was no history of pedal edema or dyspnea. She was referred for these complaints and admitted. Fluid cultures were done. She was told to have significant infection and that she may require hemodialysis temporarily. After her antihypertensives were withheld and she was also started on intravenous antibiotics and she was told to have decreasing infection. Currently, she is on 2.5%, 1.3 liter exchanges 4 times a day, no dry period, and drain is around 600 ml. Her urine output is almost nil, and she currently she is having menstrual cycle for last 3 days, and she is having blood stain fluid, so cloudiness is not assessed.
Can you summarize your findings?
She is 23-year-old female, first child of a second degree consanguineous marriage with normal
What's her age?
23 years currently. First child of a second degree consanguineous marriage with normal antenatal period, symptomatic initially diagnosed to be symptomatic from 4 years of age with recurrent UTI and told to have a backflow of urine to kidney suggestive of vesico-ureteric reflux. Underwent corrective procedure initially at 5 years of age and was on self-intermittent catheterization and had progressive worsening of renal parameters. Subsequently underwent a second procedure around 8 years of age, probably ureterostomy, and initiated on peritoneal dialysis at 17 years of age. Received 2 blood transfusions prior to 2 procedures, that is ureterostomy and PD catheter insertion, and 2 episodes of PD peritonitis in past and currently admitted with history suggestive of peritoneal dialysis, peritonitis.
So what do you think is the...
What do you think is her basic problem?
Basic disease is suggestive of vesico-ureteric reflux.
primary,
Uh,
secondary?
Suggestive of secondary, ma'am. She has history of bladder and bowel dysfunction and some straining, the stream of urine was not proper, and she had bowel dysfunction along with that. Most probably she may be having some underlying bladder dysfunction like neurogenic bladder or something causing a secondary VUR.
So, but you said the first presentation was at the age of 4 years. So
First,
do you think with neurogenic bladder, its first presentation would be at 4 years? How do they present? So how do they present?
patient was having those symptoms from birth, ma'am. It was like mother was not aware that it is like she used to pass stools every time when she had micturition.
What is the common presentation of patients with a neurogenic bladder? How do they present?
Low volume of urine and abdominal distension, incomplete micturition.
Can they have dribbling?
Yes, dribbling urgency.
Did you ask this?
Yes,
girl?
ma'am. She, like, mother is not giving the history suggestive of dribbling or urgency and all. Only thing she was telling was every time low volume of urine was passed.
What is another important, the milestone you should ask in such patient when you're expecting neurogenic bladder and VUR, secondary VUR?
Attaining continence, ma'am.
Bladder training. So did she achieve bladder training?
From 4 years,
What is the normally you expect to have bladder training in a child?
3 years day continence will be attained, ma'am. By around 5 years or maximum 7 years.
Usually they'll have a 2.5 years, they'll have a bladder training. They
Yes.
they'll have full control and they don't have incontinence. And so what is you said 4 years.
That was
So
not
did
attained.
you ask about the bladder training in this patient?
Yes, ma'am. She continued to have all these symptoms throughout all these 4 years. She did not attain continence day or night.
And what are the other symptoms you should ask, particularly when you're thinking of a neurogenic bladder?
Any structural anomalies?
They're associated in what conditions do we find a neurogenic bladder?
Spina bifida or other.
So the other milestones, whether there was any lower limb weakness, lower limb weakness,
Her motor milestones
meningomyelocele,
and all were normal, ma'am.
completely
that I had
normal.
mentioned.
Hmm.
Yes. Oh, yeah. Okay, so,
Okay, so that history is important.
yes.
Okay,
She
any other
attained
thing?
all her motor milestones normally.
Okay, any other thing?
Growth history.
Growth history is important.
Yes. She, after around 8 years of age, mother had noticed that she was short compared to her friends, and she was lean also. But there was no history of any bony abnormalities or knee joint abnormalities or difficulty in walking or bone pain, nothing like that was mentioned.
Yes, and the CKD MBD feature is also important, particularly with respect to lower limbs.
Yes.
Whether with the deformity of the lower limbs, all those things are important. Okay, so
General exam letters. Can you finish your examination findings?
General examination, patient is conscious oriented. Her height is 138 centimeter. Actually, she was not able to stand up. I had measured her length and weight was 34 kg with a BMI of 17.17, and her pulse rate was 100 per minute. Blood pressure was 112 over 80 millimeter mercury in left upper limb in supine position, and there was pallor. She had a mild frontal bossing and depressed nasal bridge. There was no syndactyly, polydactyly, cleft lip or cleft palate. There was widely spaced teeth and short stature. There was I couldn't examine her gait or in knock knees in standing posture. There was normal axillary pubic hair, breast was normal. She had pigeon chest but no rachitic rosary and all. Other system examination.
Go ahead, complete examination.
Gastrointestinal system, oral cavity, pallor was present. Per abdominal inspection, abdomen was distended, umbilicus was flat. PD catheter was seen on the right side of abdomen, and ureterostomy with the bag was seen in the left iliac fossa. On palpation, there was no local rise of temperature or tenderness. There was no mass palpable or tenderness over the tunnel, PD catheter tunnel, and fluid thrill was present. Other systems was grossly normal.
Is she bedridden?
She was not bedridden, ma'am. She was doing her exchange and she was not disconnecting that PD fluid. Like she was infusing only 1300 ml. So she was keeping that rest of the fluid connected with the catheter. That's why she couldn't stand up.
So that you mean to say like night she is not disconnecting at all. So whatever fluid is there, she is able to continue the same 2 liters back. She is using only 1.5 and she is not discarding rest of the fluid.
Yes.
Okay, okay. So coming back to the history, you told that she underwent surgery twice, isn't it?
Yes.
So what do you think is the surgery?
The second surgery is
What was the first surgery and what
first
age?
surgery was done at 5 years of age. Must be ureteric reimplantation surgery. She has history suggestive of vesico-ureteric reflux, and history-wise it is severe. So maybe and recurrent UTI also was there. Bladder bowel dysfunction also was there. Must be ureteric reimplantation surgery.
No, you can't say just bowel dysfunction because it becomes a serious issue. Most of the patients when they have this what you call associated with the bladder dystrophy and then VUR and bowel, so it becomes a syndromic manifestation. Do you think it's a syndromic manifestation with major bowel disturbances and then bladder dystrophy and then going for secondary VUR?
No.
So what is that syndrome called? Okay. So what is the first surgery and what is the second surgery? You said 5 years she underwent first surgery and the second was at the age of 7 years.
Yes, ma'am.
So what is the surgery?
First surgery may be ureteric reimplantation, and second one suggestive of ureterostomy.
Second one?
Percutaneous ureterostomy.
So why do they go for ureterostomy first, subsequently, when already she has underwent the ureteric reimplantation?
She continued to have fevers after that surgery also. On and off fever was there. Urinary infection was documented, and she was doing intermittent self-catheterization. Maybe the
A ureterostomy was done. That's what you think.
Okay. So she, reached ESRD at the age of 7 years?
17 years.
17 years.
Yes.
Okay. So what advice you would give with respect to the renal replacement therapy?
Sorry, ma'am?
What advice, what would be preferred choice in a 17-year-old girl?
RRT, she can, options are renal transplantation and dialysis. And for her, she was started on peritoneal dialysis. Peritoneal
So
dialysis.
what would you prefer if were to be your patient? So what would you prefer?
Renal transplantation is an option, ma'am, but she should be counseled regarding the complications because of her underlying vesico-ureteric reflux and the already done surgery. She
requires a lower urinary tract evaluation before considering for transplantation.
Yes.
Okay, good. Then?
Then regarding dialysis, peritoneal dialysis, she has opted for peritoneal dialysis, which is okay. Like she.
Now why do you prefer peritoneal dialysis over hemodialysis?
Peritoneal dialysis in patients with preserved residual renal function, peritoneal dialysis has found to be a better outcome in the initial years.
So that is with respect to any patient. So
Yes.
particularly this patient in a pediatric age group. So do peritoneal dialysis preferred compared to hemodialysis?
One thing is her schooling, she will be more free, and her schooling and all will not be interrupted with peritoneal dialysis. Next thing is her vascular access. Though she is 17 years, because her growth was small, she is more like a pediatric patient, so it will be difficult to create and maintain a vascular access in those patients. So considering that also, peritoneal dialysis would be better.
Okay, good.
You think this girl had peritonitis.
Yes.
Do you think, what is your diagnosis? What sort of peritonitis? Is it refractory peritonitis? Is
Current
it
one.
a relapsing peritonitis? What is the difference between the two?
Refractory peritonitis is when a peritonitis is not cleared. That's when cloudy effluent is persisting after 5 days of appropriate antibiotic
After?
therapy. 5 days of appropriate antibiotic therapy. Then
Recurrent.
recurrent peritonitis is when after completion of a peritonitis treatment, within 4 weeks, she has another episode of peritonitis with a different organism.
Okay. Like you said, peritonitis, PD is a preferred option. So while placing a PD catheters, what are the precautions you take, particularly with respect to a child?
With respect to infection, ma'am?
No. This patient, so you want to place, now they have agreed for PD.
Yes.
And you want to place a PD catheter. So what is the precaution you take while placing a PD catheter?
Prophylactic antibiotic should be given.
Okay.
Then
I'm telling about the pediatric population.
size of catheter should be
Okay. Any specific complication you encounter in pediatric population? What is the common complication you see?
due insertion related complication, ma'am? I'm not getting.
What is the mechanical complication you encountered in pediatric patients with PD?
Omental wraps.
Omental wrap. So you have to go for a omentectomy while placing a PD catheter, that you can take care, because they frequently come with a mechanical complication of omental wrap. Okay, but she never had that, and she didn't undergo
Any procedure
omentectomy
post
also.
insertion.
Okay. Okay. So what was the first infection episode in
When
this
was-
patient within a period of
After 4 months of catheter
4
insertion.
months? Okay. So what is the latest additions in the newer ISPD guidelines with respect to peritonitis?
One is catheter insertion related peritonitis.
So what is that they have called time
Catheter
definition of the peritonitis? So what is that called? They have added one
Catheter
term.
insertion related peritonitis is within 30 days.
Pre-PD peritonitis, isn't it?
Pre-PD
So does it fit into a pre-PD peritonitis?
No, ma'am.
Why?
Pre-PD peritonitis is after insertion of PD catheter before PD initiation. That is
Okay,
when
PD commencement.
PD commencement.
So within usually 1 month. Okay. So this patient had after 4 months. So that doesn't include under the
Pre-PD peritonitis.
Okay. ठीक है. What is PD catheter related peritonitis?
PD catheter related peritonitis is when one develops a peritonitis within 3 months of tunnel infection or exit site infection with the same organism, or
No, PD catheter related peritonitis.
PD catheter related and catheter insertion related peritonitis.
No, PD catheter insertion is different. PD
Yes,
catheter related peritonitis is different.
Catheter related peritonitis is when one develops PD peritonitis within 3 months of an exit site infection or tunnel infection with the same organism, or a sterile organism if we received antibiotics.
Okay, good. So they are often associated with exit site infection or the tunnel infection. Okay, ठीक है. Okay, so when do you call refractory? That is, madam has asked that refractory peritonitis. And how do you treat refractory peritonitis?
Refractory peritonitis catheter has to be pulled out, ma'am. It has to be removed.
Catheter has to be removed. So what are all other conditions where catheter has to be removed?
One is refractory peritonitis, one is fungal peritonitis, one is like a relapsing, recurrent or repeat peritonitis with reinsertion. We can remove and reinsert. Then
Now, when do you want to reinsert?
sorry, ma'am.
When do you want to reinsert the catheter?
In relapsing and all, once the PD culture is sterile, we can remove and reinsert in a same sitting.
What is that called? Simultaneous
Yes.
catheter removal replacement. So usually that occurs only in mechanical complication we can do, not with infective complications. You want to insert, you remove the catheter, wait for 2 to 4 weeks and then reinsert. In infective complications we can't do simultaneous removal and reinsertion. Okay? Okay, right. Okay, so you said PD prescription. I mean, what is the PD prescription she received?
Initially, she was on 1.5%, 1000 ml, 3 exchanges of 4-hour duration during night.
How do you prescribe a PD prescription?
Like in children, it can be 20 to 40 ml per kg or 800 to 1200 ml per meter square body surface area.
Okay.
In adults, it can be 1.5 liter per meter square of body surface area, and further it can be increased.
The average is 30 ml per kg body. It's only the volume or any other thing? What are all the various parameters you have to consider while prescribing a PD? One is volume, okay, then?
Concentration of the PD.
Yeah, how do you decide concentration?
We can start with the low concentration of PD fluid, and further, depending on the transporter status or ultrafiltration, we can change the concentration.
Then volume, concentration next.
Then dwell time or
Dwell time,
type
okay.
of PD.
How much dwell time you want to have to begin with, and later on if you want to change?
That also depends on the residual renal function of the patient. We have to
Usually dwell time doesn't depend upon the residual renal function, it depends upon the transporter status,
yes.
isn't it?
Initially we can
So which patients you want to prefer long dwell times and which patient you want to have a shorter dwell times?
shorter dwell times are given for patient with fast transporter status, and for patients with slow transporter, long dwell can be
Why?
used. Because they will get more ultrafiltration, and exchange also, like solute exchange also requires more time because of the slow transporter status.
No, if a high transporter, if you prolong the dwell time, what is the complication?
Reabsorption of fluid can occur.
Okay, because the high transporter, glucose get reabsorbed and then ultrafilter, whatever ultrafilter that also gets into the body. Okay, so you should have a short dwell time for the high transporter, correct. So you said in this patient after having a second episode of peritonitis, ultrafiltration has reduced, isn't it?
This is the third episode.
Third episode, okay. So what do you think is the reason for that?
Currently she is having peritonitis, which is an inflammatory state, and that can cause a transient fast transporter status like in the peritoneum, resulting in fast transporter like decreased ultrafiltration failure, type 1 ultrafiltration failure can
Very
occur.
good. So this is one of the type of ultrafiltration failure, particularly subsequent to a peritonitis episode.
Yes.
Okay.
Are you regularly doing PET these days?
PET we will do once inserted. After 4 to 6 weeks of insertion, we will do a PET test.
But
After that,
I mean, most of the centers have now given up doing a PET test. What are the different types of PET that we can do?
PET test can be standard PET test, mini PET test, double mini PET test. Uni PET test, not sure.
How do you assess the adequacy of PD?
Adequacy of PD is assessed by KT by V.
Apart from KT over V is a formula. Apart from that,
Creatinine clearance also can be assessed.
What is the, again,
Other
PD
parameters.
guidelines have actually changed the adequacy of, the definition of adequacy of dialysis. So what is that? It's just a number or something else?
With the adequate functioning, like general functioning of the health of the patient also has to be considered more than just a number. Even if it is low, if patient has good clearance or other biochemical parameters, if it is normal, hemoglobin is normal, if he is maintaining well, then we need not
So
stick on to the
clinical
clinical
assessment.
parameters.
So you said KT by V. So what is the, when do you call it is adequate as per the KT by V?
For peritoneal dialysis, around 1.7 is the suggested combined renal and peritoneal KT by V. And less
how did we arrive at that 1.7?
the trials assessing the KT by V, like 1.7 was assessed in the like suggested in the Hong Kong trial, where it was found that 1.7 was adequate, and whatever less than 1.5, they had an increased erythropoietin use. And
More important than what are the two major landmark trials?
Canusa trial and Adimex trial, ma'am.
ADMEX trial and Canusa trial. Okay.
Canusa trial showed a KT by V of 2.1, and whatever less 0.1 decrease from that was increasing a mortality of around 6%. And Adimex trial showed that diabetes, age, albumin also were more important parameters along with KT by V.
Okay. So, how do you treat a peritonitis? This patient, she had peritonitis, no? So, all 3 episodes of peritonitis. How do you treat a peritonitis?
Peritonitis treatment has to be started empirically whenever we diagnose peritonitis when patient has 2 out of the 3 features. That is, clinically patient has an abdominal pain with or without cloudy effluent, and the leukocyte count, the peritoneal fluid leukocyte count is more than 100 with more than 50% of polymorphonuclear leukocyte, and there is a positive culture. And 2 out of 3 will diagnose peritonitis. When patient is suspected to have clinical peritonitis, we have to send the sample for cell counts and cultures, and we have to start on empiric antibiotic therapy covering both gram positive and gram
How
negative.
do you send the sample?
Sample has to be ideally sent in a blood culture bottle after centrifugation. That increases the yield of
How much fluid should be sent?
50 ml of peritoneal.
20 ml,
Yes,
50 ml.
50
Ideally,
ml.
you send the entire bag.
Bag has
They
to be
take out the 50
central.
ml and then what's the
Centrifuge.
practical problem? Did you go to your microbiology lab and see whether they are taking 50 ml? Or they are taking some few ml and then centrifuging? So what is your culture negative? When do you call culture negative peritonitis?
Culture negative peritonitis is when patient has the other two factors of other 2 points of peritonitis, diagnosing peritonitis with the culture that is negative.
So one of the two, either should be clinical or the cloudy fluid, one of the two, along with culture should be negative.
Negative.
So what is the reason why you are getting culture negative?
That may be one causes recent antibiotic use. Second is suboptimal sample collection or cultures, or it may be due to a slowly growing organism or atypical organism.
So most of the time what we see is you
Sample.
don't take a proper sample, 50 ml, they don't centrifuge, they just take few ml and they put it in the the plates. Okay, so inappropriate sample collection and processing is the main reason in our centers, and of course the prior antibiotic usage. Okay. So what is the accepted culture negative peritonitis rates?
Should be less than 15%.
Okay, 20%, less than 20%. Okay. Take it then. Continue with the treatment of peritonitis.
The patient should be given empiric gram-positive coverage that was with the first generation cephalosporin or vancomycin, depending on the local antibiogram, and
So initial empirically should
cover both
cover both and gram positive and gram negative, and that depends upon the
The hospital.
Yes, usually the hospital institution can choose the antibiotic coverage based upon their pattern. Okay.
And along with that, pain and has to be addressed, and heparin, if patient has cloudy effluent or fibrin threads, heparin.
How do you give the antibiotic?
Intraperitoneally we can give. That is, if for vancomycin, we can give
For gram-positive.
gram-positive, we can give, if we are giving vancomycin once in 5 to 7 days, if a patient is on CAPD, with a dose of 15 to 30 mg per kg, and if patient is on APD, every 4th day we have to repeat.
What precautions? When do you give this antibiotic?
It has to be given during the long dwell time, and
Minimum hours?
6 hours dwell is suggested.
4 hours.
Okay. So patient has come to you and then patient is not having any dwell volume. So we want to send a sample for the processing, the culture. So how long the dwell should be there? You just put a fluid inside, take out and send, or what is the time duration, minimum time duration for you to have the proper sampling?
Minimum of 1 liter for around 2 hours should be kept.
2 hours. There is another reason for culture negative peritonitis. Okay.
This child is planned for.
So now, what is the status of the patient now?
Currently, patient is told to have decreasing counts but not fully cleared.
This patient has, he said, evidence of bone disease. Did you say that?
Ma'am, she has a short stature, then some frontal bossing is there, and the pigeon chest is also there. But knock knees were not there.
Were you given any lab values?
No, ma'am.
No. Okay, this child, calcium is 6.7, albumin is 2.6, phosphorus is 4.3, and PTH is over 2000. Alphas is 1276.
She's having hyperparathyroidism and mostly secondary hyperparathyroidism. She has hypocalcemia, even if it is corrected, it is low. And phosphorus, though in normal range, she is getting adequate, significant amount of phosphate binders, and PTH is more than 2000.
And her culture shows a Pseudomonas aeruginosa. So how do you want to treat now?
Pseudomonas, if there is no exit site or tunnel infection, currently she is not having features of exit site or tunnel infection, we can give antibiotics. That means if there is an exit site or tunnel infection with Pseudomonas, catheter has to be removed. If not, we can give antibiotics for
Which
and monitor.
antibiotic?
Sorry, ma'am.
Which antibiotic? Pseudomonas.
Yes, ma'am.
How common is Pseudomonas in the
Less common in PD peritonitis. Aminoglycosides, IP, and currently she is on IV antibiotics. 2 antibiotics has to be given.
Again, it depends upon your
Hospital
local antibiogram.
and
But
sensitivity.
generally, if there is Pseudomonas, you at least give a high-end antibiotic,
Yes.
like carbapenem.
Yes, IV or IV.
And is
carbon.
there any duration, like specific duration for the treatment? What is the conventional duration of treatment, and how do you treat in case of a Pseudomonas?
Pseudomonas patient should be getting 3 weeks of antibiotic therapy.
Usually
2 weeks.
2 weeks. Okay. You have time or still you have time? Huh? Over.
Thank you.
Okay.
Thank you, Dr. Vidya.